I'm going to talk to you about complications of healing after these physeal injuries. And we will find that we are halfway through our session, so hopefully you have a good introduction to these physeal injuries, and I'm here to tell you what can possibly go wrong. So much of my talk is taken from this brilliant book written by Hamlet Peterson from the Mayo Clinic. I encourage all of you to read this. It's a very thorough, very detailed book, and it goes through physeal injuries very, very well. Before I get into what can go wrong with the healing of the physeal injuries, I still want to emphasize that you still have to take care of the acute complications, okay? So you still have to take care of the vascular injuries and neurological injuries, things like compartment syndrome and open fractures. These things all have to be dealt with well before you can go on to the subsequent complications of physeal injuries. Now, in Hamlet Peterson's book, he talks about complications which he calls manifest later, and there's a long list of them. And I actually took the liberty of renaming that, and this is actually really just complications of healing after physeal injuries. And there are two main groups. There are those injuries that happen which are not specific to physeal injuries, like non-union and malunion. And then there are injuries that are specific to the fact that these injuries occurred at a physis. So we'll go through the non-specific complications first, things that can pretty much happen anywhere in the body. It just happens to be a physeal injury. Now, non-unions classically happen in lateral condyle fractures. This is a contribution of the pull of the extensor tendons and also the intra-articular nature of the injury. So this is a boy who had the injury, refused all treatment, and then disappeared for months before coming back with a bump over the lateral aspect of the elbow. So non-union does happen in physeal injuries. You can also get malunion. Occasionally, this can happen without it developing any physeal arrest. And so this will cause an angular deformity, but not a progressive one. However, more commonly, this will actually cause a physeal arrest, and these patients will present with a deformity which gets progressively worse with time. And unfortunately, this is really an iatrogenic problem. These things happen because the injury was not reduced well and not fixed properly. And there are other non-specific injuries such as synostosis, heterotopic ossification that leads to loss of range of motion, but they really are quite rare and exist in the literature just as case reports only. Now we get to the big topic of complications that happen that are specific to the physeal injury. And of course, the biggest thing that we're all worried about and all concerned about is the physeal arrest. And as mentioned before, there are many different ways to classify them, but essentially you're looking at the Salter-Harris classification here. Essentially, this will really happen if the injury passes through the resting zone of the physis or the germinative zone where the progenitor cells lie. Now, if the physeal arrest happens in over 50% of the physis, this will lead to shortening of that particular bone. The amount of limb length inequality that you finally get will depend on two things. One is how much that physis contributes to the longitudinal growth of that particular bone. And secondly, how old the patient is. How much growth does he have remaining in his life? So for example, you will see here, this is a complete growth arrest of the proximal tibia. And over here, we have one boy who had a growth arrest of the distal femur in childhood, and by the time he reached skeletal maturity, the length discrepancy was 7 centimeters, quite significant. In contrast, this is a boy who had an injury to his distal tibia, very young, at 3 years of age, but by the time he was 13 years old, the length discrepancy was only about 4 centimeters. So this is because the distal tibia physis contributes less to the overall length of the lower limb, and that's why he gets less limb length inequality. If the physeal arrest occurs in less than 50% of the physis, then you'll get an angular deformity. So for example, you see here a fracture through the medial aspect of the distal tibia physis, and this with time results in a varus deformity of his ankle. Now, us pediatric orthopedic surgeons, we would be tempted to simply put in a guided growth procedure, such as an 8-plate in this patient. However, as you can see, this is actually 2 years after the insertion of the 8-plate, and it didn't work, nothing corrected. And that's because for 8 plates to actually work, you actually still need sufficient growth from the remaining half of the physis. And if it's actually too far gone, then it won't work. But I'm sure you'll hear more about this later when we talk about how to actually manage physeal arrest. A less common complication after physeal injuries is ischemic necrosis of the physis. And this can occur because the resting zone of the physis receives its blood supply from the epiphyseal artery. So if there is sufficient trauma to disrupt the epiphyseal artery, you can actually get ischemic necrosis of the entire epiphysis and also the physis. This is not my case. This is taken from the chapter by Dr. Peterson. I myself have never seen it, but this theoretically can happen. And then lastly, we talk about overgrowth. Now, the most common type of overgrowth is simply relative. It's not genuine. For example, we have this boy here who was hit by a taxi. He had a distal radius fracture. We pinned it, but actually with time, we found that he had a growth arrest of the distal radius. And from the x-rays, you see that there is a relative overgrowth of the distal ulna. The distal ulna hasn't grown more, it's simply longer relative to the distal radius. He has a lot of impingement symptoms, and so we eventually did an ulnar shortening osteotomy for him. But you can get genuine overgrowth after a physeal injury, and this is the most classic example. After a lateral condyle fracture, you have an overgrowth of the lateral aspect of the distal humerus. Now, some people say that this may be due to the elevation of the periosteum, but as you can see here, we did an open reduction. It's a perfect reduction, good fixation, and it healed well, but still somehow on the lateral aspect of the lateral condyle, you see this overgrowth of bone here, which results in a bump for the patient. And we do warn them of these problems beforehand, so they're not surprised by it afterwards. You can also get genuine overgrowth of the adjacent physis, either the physis in the bone itself. So for example, if there's a severe distal proximal tibia injury, the distal tibia might try to grow more bone to make up for the length, or actually in this case, the physis of the distal femur overgrew to make up for the leg-length discrepancy experienced by this patient. But this is less common. And finally, you can get a genuine overgrowth of the ossification center, such as this case report here, where the olecranon overgrew so much it no longer fit into the olecranon fossa, and it caused a reduction in the extension of this elbow. And this is an example from Dr. Peterson's book where the medial malleolus actually overgrew after a malunion and a growth arrest. Even after the osteotomy, the medial malleolus actually overgrew compared to the other side. So complications of healing after physeal injuries can happen in the upper limbs and the lower limbs. Most commonly, it results in some sort of growth arrest, either partial or complete, but occasionally even overgrowth can occur. Thank you for your attention.